Hello everyone, welcome back to the channel. Today we're going to be doing a very special episode. We're going to be learning about Alzheimer's disease and dementia, the next in the neurology series. So in this lecture we will cover the following. We'll mainly be defining dementia, going through the different types of dementia, and talking through a bit about how they differ and their management, and hopefully lots of SBAs to help you practice. So, what is dementia? Dementia is the irreversible and progressive decline in cognitive function. So, that can include a decline in concentration, memory, speech, language, personality, emotion, but without an impairment in the level of consciousness. So, they're conscious. But experiencing an irreversible progressive decline in cognition. It typically, the biggest risk factor is usually age, so it's more common in the elderly, and it can only be proven post-mortem. So here are some of the causes of dementia. We can remember it using the mnemonic VANISHED, so you can have a look at this. The key important ones to remember is the folate, B12 and thiamine deficiencies. Another quite important one that comes up quite a lot is subdural hematomas and hypothyroidism, as well as normal pressure hydrocephalus. And in terms of electrolyte imbalances, the main ones that can cause dementia include hyponatremia, hypokalemia, hypocalcemia, and hypercalcemia. So dementia presents with the 7 classical A's: anosognia, which is an ignorance of the presence of the disease, so they won't realize that they have the disease. Agnosia, the inability to recognize objects using your senses. Aphasia, inability in speech or language. Apraxia, inability to perform purposeful movements. Altered perception, so inability to sense information. Apathy, lack of interest in activities. And amnesia, memory loss. So all of these kind of signify some cognition, such as speech, movement, senses, memory, and all of these will be reduced in a patient with dementia. We can diagnose dementia with a series of bedside bloods and imaging. So in terms of bedside, the key investigations we do is screening tools. So we can use a 10-point cognitive screening tool. You can look through on Google the criteria for that, and the 6-item cognitive impairment tool. So the higher the score, the greater the level of impairment in cognition, and that indicates potentially dementia. We can also confirm it with a series of bloods. So in terms of the things we're looking for risk factors. So B12 and folate deficiency can cause dementia. We're looking for and that will help us to possibly suggest a diagnosis of dementia. Hypocalcemia, hypercalcemia, all of these things, infective markers, and thyroid function tests for hypothyroidism, hyperparathyroidism, all of these to help us to rule out and rule in causes of dementia. And in terms of imaging, we can do neuroimaging to explore some of the reversible causes, subdural hematomas, normal pressure hydrocephalus. And the point of the bloods and the imaging is essentially to rule out and rule in, to identify reversible causes so we can treat the underlying cause and stop it from contributing towards dementia. So here is a question, have a go. So I'll move on. The correct answer is E. None of them are causes of dementia. If you go back to the mnemonic VANISHED, none of them are causes of dementia. The main ones I would have it between is D and E. Hyperthyroidism is a cause of dementia, not hypothyroidism. So high levels of the parathyroid hormone is a risk factor of dementia. And the correct answer is actually E. So hypothyroidism is the most likely cause of dementia. All of the others are not causes of dementia. And the trick was with D is hyperthyroidism, not hypothyroidism. Now, Alzheimer's. Alzheimer's is the most common type of dementia. It's a progressive neurodegenerative disorder, so it steadily worsens over time. You get a gradual cognitive decline, and it can present with memory impairment, behavioral changes, and the main pathophysiology of Alzheimer's disease is it's caused by the buildup of beta amyloid plaques and tau proteins, which can kind of fumble up and mesh together to form neurofibrillatory tangles in the brain. There's also some genetic risk factors and genetic associations that you need to be aware of. So, for example, having a family history is going to increase your risk of early onset dementia. 5% of dementia is inherited as an autosomal dominant trait. It's also associated with the APP mutation on chromosome 12. And speaking of chromosome 12, there's an association with Down syndrome, which is caused by the APP gene located on chromosome 12, and the higher expression of the APP gene can result in trisomy. So that means that Down syndrome there's an association between Down syndrome and Alzheimer's. And other genetic risk factors that you need to be aware of is the APOE4 gene, which encodes cholesterol transport proteins, and that can potentially contribute to the buildup of beta amyloid plaques due to it causing a less effective breakdown of the beta amyloid plaques. And all of this can contribute towards Down syndrome. Now, there are both, in terms of the findings that we want to look for when we are investigating Alzheimer's disease, there are a series of microscopic, macroscopic, and biochemical changes that we want to be looking out for when trying to diagnose Alzheimer's. In terms of microscopic, some of the large changes can include a widespread cerebral atrophy, so that leads to the shrinkage of the cortex and the shrinkage of the hippocampus, enlarged ventricles, and as you can see here, the main site affected in severe Alzheimer's is the cortex and the hippocampus. In terms of the microscopic changes, as we said before, you'll have a buildup of the beta amyloid plaques and depositions, and this can kind of tangle together to form neurofibrillary tangles due to the tau proteins become aggregated together, and the tau proteins are also hyperphosphorylated. In terms of the biochemical changes, you'll have acetylcholine deficits, and there's a reduced transmission of the acetylcholine choline neurotransmitters, and this reduces the transmission of information throughout the neurons and causes the death of brain cells, which results in cognitive deficits. And in terms of the presentation, the key thing is to look out for is an elderly patient with global impairment. They may have changes in behavior and particularly a progressive decline in memory, leading to memory loss, and also changes in things like planning, reasoning, speech, and orientation. In terms of the management, there's a useful mnemonic called Grandma Doesn't Remember Me, which can help us to remember the drugs that we can use to manage Alzheimer's disease. So G for galantamine, D for donepezil, R for rivastigmine, M for memantine. The first line is usually galantamine, donepezil, and rivastigmine, so grandma doesn't remember. And these are essentially actually, before we even do any pharmacological intervention, we want to first try and treat the patient with non-pharmacological interventions. So some of these conservative management techniques includes offering a range of activities to promote well-being, such as cognitive stimulation therapy and considering cognitive rehabilitation. And then if those conservative measures don't work, then we want to move towards pharmacological interventions such as the acetylcholine esterase inhibitors, galantamine, donepezil, and rivastigmine, which is really useful in mild to moderate cases of Alzheimer's. The key thing to note is that donepezil is contraindicated in bradycardia, and it can cause anosmia, so difficulty sleeping. So you don't want to give it in patients who have sleeping disorders or have symptomatic bradycardia. And then second line, if we can't give acetylcholine esterase inhibitors, or if we have a very moderate to severe case of Alzheimer's, then we want to consider memantine, and this is an NMDA receptor antagonist. And this is usually preferred in moderate to severe cases or where acetylcholine esterase inhibitors are contraindicated. Now, the next thing we want to be aware of, the next type of dementia includes vascular dementia. So this is a type where it's associated with vascular disease. So this can include pathology such as hypertension, atrial fibrillation, PAD. So it usually occurs over several months or years. There's a stepwise decline. So what that means is you'll have periods of stability where they're completely fine, they're normal, and then a very sudden acute decline where they're suddenly getting worse, and then again back to a period of stability, and then again they suddenly drop in their levels of dementia, whereas this compared to Alzheimer's, which is more of a progressive decline over time. There are many subtypes of vascular dementia. So the first one is stroke related. So this happens usually after an infarct, either a single infarct or a multi-infarct. And this causes generalized intellectual loss. There's also subcortical vascular dementia, which happens in small vessel disease, and this is caused by a gradual accumulation of small strokes that will cause dementia. And then there's mixed dementia, which is when the patient has both vascular dementia and Alzheimer's dementia. So as I said, the biggest risk factors for vascular dementia includes anything that's vascular related. So that's diabetes, hypertension, metabolic syndromes, being elderly, being male, stroke, atrial fibrillation, genetic risk factors. Is the most common one, the risk factor you need to be aware of is stroke and TIA, and the fact that it's at greater risk in the elderly and males. Another very important risk factor is hypertension and of having a family history of cardiovascular disease or stroke. Some of the genetic factors that can contribute to vascular dementia include CADASIL, which is essentially a cerebral autosomal dominant arteriopathy with subcortical infarcts, and leukoencephalopathy. And some of the changes in the ways that this can present is usually as behavioral symptoms, so memory loss, slowed thinking, depression, anxiety, motor local problems, so gait disturbance, dysarthria, autonomic dysfunction, and a loss of executive functions, so problem solving, working memory, judgment, and reasoning. Now, in terms of presentation, as I said, there's a range of behavioral, locomotor, and loss of executive function. So other common ones to keep an eye out for is focal neurological deficits, visual disturbances, gait disturbances, disturbances in memory and speech, attention and concentration seizures, and psychotic symptoms such as depression, psychosis, and emotional liability. Emotional liability is usually when there's rapid and often exacerbated changes in the mood and very fluctuating differences in strong emotions and feeling. For example, the patient can go from uncontrollable laughter to crying, as well as heightened irritability or temper. In terms of diagnosis, again, a series of bedside, bloods, and imaging. The main criteria to keep an eye out for in terms of vascular dementia is the NINS-Aaron criteria, and this assesses, you don't need to know exactly the points of the criteria, but it's good to be aware of it, and it just assesses the cognitive decline of the patient and how it interferes with their activities of daily living. We can also do assess for their cardiovascular signs within the brain, and then also do imaging such as MRI scans to look for infarcts and extensive white matter, which can indicate cardiovascular disease. And in terms of the management, firstly, we would only treat them if they were symptomatic. Assess for cardiovascular risk factors. Firstly, the non-pharmacological intervention would be cognitive stimulation. So, for example, multi-sensory stimulation, music and art therapy, animal-assisted therapy, manage their behavior, so help with communication. And in terms of pharmacological, we can also give them acetylcholine inhibitors or memantine, so quite similar to Alzheimer's. Lewy body dementia is associated, the main presentation here is a fluctuating cognition. It's associated with Parkinson's disease and Lewy bodies. So Lewy bodies are essentially abnormal deposits of a protein called alpha synuclein in the brain, and it affects the chemicals in the brain, which change and in turn can lead to problems with thinking, movement, behavior, and mood. And these Lewy bodies are usually found in the substantia nigra or paralimbic and neocortical areas, and it's more widespread in patients with Alzheimer's disease, which is why there may be potentially the association between Parkinson's disease and Lewy body dementia. There's also a fluctuating cognition, so um, you know, in terms of this, there will be a progressive cognitive impairment. So the Lewy body dementia will usually precede the motor symptoms. It's quite fluctuating, so an on and off kind of presentation of the symptoms, and there may be an early impairment in attention and executive function, for example, problems with multitasking, and also Parkinsonism. So look out for symptoms such as a wide step shuffling gait, cogwheel rigidity, bradykinesia, tremors, and all of this falls, and all of this happening in a fluctuating on and off manner. And another thing to note is that in terms of Parkinsonism, it should not precede cognitive decline by more than 1 year. So it should have happened at least within the last year of the cognitive decline happening. And there can also be visual hallucinations. So Lewy body dementia, think fluctuations in cognitions, Parkinsonism, visual hallucinations, and Lewy bodies. Now, in terms of the diagnosis, we can use a series of bedside bloods and imaging. The main imaging here is the SPECT, or the DAT scan, and that helps us to quantify the dopaminergic neural loss. And in terms of management, we can use acetylcholine inhibitors, so donepezil, rivastigmine, and memantine. And it's really important to avoid neuroepileptics that can cause irreversible Parkinsonism. So again, very similar type of management to Alzheimer's. So the last one being frontotemporal dementia. So this typically causes dementia in younger patients. There may be preserved memory and visuospatial skills and behavioral personality change. You can have neural damage and death in the frontal and temporal lobes, atrophy due to abnormal protein deposition, and is associated with ALS. It's also associated with the Pick's disease, which is altered emotional responsiveness, apathy, disinhibition, and impulsivity, a progressive non-fluent aphasia, progressive breakdown in the output of language, semantic dementia, decline in the understanding of words, meanings, difficulty in the use of less precise terms, and prosopagnosia, which is called face blindness and is a condition where you have difficulty in recognizing people's faces. NICE does not recommend that acetylcholine inhibitors or memantine is usually used in patients with frontotemporal dementia. So note this is the only type of dementia where we wouldn't recommend acetylcholine inhibitors or memantine in terms of its treatment. Normal pressure hydrocephalus. So this is a reversible cause of dementia. It's caused by an abnormal buildup of CSF in the ventricles due to reduced reabsorption. The treatment is usually to drain the CSF using the ventriculoperitoneal shunt. And the main thing you want to remember is, in terms of symptoms, the triad of weird, wet, and wobbly. So weird meaning cognitive changes, dementia, so thinking, wet, urinary incontinence, and wobbly, so take ataxia, gait disturbances. And weird, wet, and wobbly suggests that we have normal pressure hydrocephalus. And in terms of investigation, we want to use imaging to look for hydrocephalus. You can see on the image on the right, and it'll show the ventricles being quite enlarged without any sulcal enlargement. And some of the biggest risk factors for normal pressure hydrocephalus include being elderly, head trauma, infection, tumours, and SAH. And finally, we have Creutzfeldt-Jacobs disease. So this is caused by infections, prions, which can induce amyloid folding, tight beta-plated sheets, which are resistant to proteases. And the main thing to remember is that there's three types: the sporadic CJD. So these are normal prion proteins that spontaneously changes to a prion. So the normal gene spontaneously changes into a faulty gene, and that produces prions, and infectious prions causes Creutzfeldt-Jakob disease. There's also the variant CJD, which is caused by the same strain of prions, and it causes bovine spongiform encephalopathy, or also known as mad cow disease, and the prions are spread through cattle, and once that are fed to humans through infected meat. And this contains the traces of the infected brains and spinal cords, and then the prions, once they end up in the processed meat, they enter the human through food and ingestion. And then there's iatrogenic Creutzfeldt-Jakob disease, which is more common between 1958 and 1985, but it's essentially when you have human growth hormone that was used to treat children to restrict their growth. It was extracted from the pituitary glands of human corpses, and the minority of these children developed CJD, as the hormones they received were taken from the glands infected, in the glands of those infected with CJD. So the main features is it's quite a rapid onset dementia with myoclonic psychological symptoms, and minor memory lapses, and mood disturbances, and it can cause death within 6 to 13 months. So it's quite serious. And how we'd want to investigate it mainly with checking the CSF, EEG, which shows biphasic high multitude sharp waves, MRI, which shows hyperintensity in the basal ganglia and thalamus. This is the dementia cheat sheet. I would learn this quite well, so make sure to have a look at this. Is this because the patient has risk factors such as atrial fibrillation, and they are also elderly, so we are suspecting vascular dementia. The answer is Lewy body. She has fluctuating cognition, signs of Parkinsonism with the tremor, the bradykinesia, and the progressive decline and the unsteady gait, and the fluctuation in cognition. So we're suspecting, as well as the visual disturbances, Lewy body dementia. So this is Alzheimer's. We've got an elderly male associated with an impairment in his memory, social skills, changes in behavior and mood, without Down syndrome. And remember, Down syndrome is associated with Alzheimer's. So this is Donapril. The images show brain atrophy and tau protein, so these are all associated with Alzheimer's. Again, elderly male, losing memory, forgetting people's names, decline in memory and cognition, with the images giving clues of brain atrophy and tau proteins. We do have vascular risk factors, but the images would point more towards an Alzheimer's kind of picture, and the first line is usually acetylcholine esterase inhibitors, so Donapril. Thank you so much for watching. If you have any feedback or any comments, please feel free to comment and like and subscribe. Thank you for watching.